Right, so this is my video about differential diagnosis and clinical reasoning. So what is differential diagnosis? Differential diagnosis is the process of distinguishing a particular disease or condition from others that present with similar symptoms. Essentially, it is a process of elimination that uses the assessment and history-taking process to gather information on past and present symptoms in order to identify probable causes of a disease state. A list of differentials can be as long or short as necessary. However, it must prioritise the most urgent life-threatening probabilities in order of severity and eliminate them accordingly. The formulation of a differential diagnosis comes under the heading of clinical reasoning, and clinical reasoning is a process by which healthcare professionals funnel their thinking towards a likely diagnosis. So, there are 8 stages to the clinical reasoning process. Number 1 is consider the presenting complaint. Number 2 is collect information in the history and examination process. Number 3 is process the information gained. Number 4 is identify any problems or issues. Number 5 is establish goals. Number 6 is plan and implement. Number 7 is evaluate outcomes. And number 8 is reflect and learn from the process. The 2 most widely used methods of clinical reasoning include the hypothetico-deductive and pattern recognition intuitive reasoning models. The hypothetico-deductive model is a method of clinical decision-making that involves the construction of conscious clinical hypotheses that are constantly evolving, scientific and open to scrutiny. During this process, new information is constantly coming to light, which means that the clinician must perpetually generate and regenerate a differential diagnosis in order to arrive at a final hypothesis or diagnosis. Recognition and intuitive reasoning are learned through a system of repetition and the linking and grouping together of similar events. These processes are open to bias and diagnostic error, as they rely on the clinician's personal experience, knowledge and level of clinical gestalt in order to formulate an accurate diagnosis. A practitioner's level of skill, clinical experience and self-awareness are important components when attempting to reduce diagnostic error and improve clinical outcomes. Therefore, it is important to be aware of self-limitations and boundaries and to remain objective in order to systematically gather accurate clinical information and prevent diagnostic error. So, methods of assessment. The comprehensive and focused models of assessment are the 2 most widely used methods of history taking. The comprehensive method is exhaustive in nature and takes a thorough head-to-toe approach of the patient's presenting complaint. The focused model of assessment tends to be used when the practitioner knows the patient and a less exhaustive problem-solving approach is needed. The ABCDE approach is also widely used in acute life-threatening situations as it provides a systematic and timely head-to-toe assessment of the acutely unwell patient. Forming a list of differentials. So let's use a case study. Mr. X is 57 years old and self-presenting to the ED with a complaint of non-traumatic sudden onset left-sided chest pain. At nursing triage, a full set of observations are performed and an ECG obtained. Laboratory blood investigations including FBC, CRP, U&E, coagulation screen and troponin are also sent for analysis. So the patient's blood pressure is 132/74, so he is normotensive. His pulse is 108 beats per minute, so he's tachycardic, and he's got a low-grade pyrexia at 37.9. His respiration rate is 24, so that is slightly elevated. His O2 sats are 95% en route air, so they are within range. His BM is 6.9 and he's not diabetic. And an ECG confirms sinus tachycardia with no ST elevation, depression and a normal QRS complex. So with this basic information and before performing a full diagnostic assessment, a list of differentials in order of severity could include, from a cardiac point of view, it could be an NSTEMI. He's not a STEMI because we've seen from the ECG that ECG is actually just sinus tachycardia. So it could be an NSTEMI, it could be an unstable angina, or it could be a pericarditis. From a respiratory point of view, it could be a PE, it could have a pneumothorax, it could have developed a community-acquired pneumonia, it could be a pleural effusion, and it may even be an exacerbation or infective exacerbation of a COPD. Gastrointestinal, it could have an ischemic bowel, it could have a viral splenomegaly, it could be constipated, or it may have GORD. Others may include shingles, it may be anxiety-related, or it may just be idiopathic, non-specific chest pain. So how do we begin to narrow down these potential problems of the patient's chest pain? So after taking a full history and performing a full diagnostic assessment, a more accurate clinical picture begins to emerge and the differentials can be narrowed down even further. For example, from a cardiac point of view, his ECG shows sinus tachycardia with no ST elevation, depression and a normal QRS, so we can rule out an NSTEMI. Rule out a STEMI, not an NSTEMI at this stage. His pain is dull in nature, worse on deep inspiration, and non-radiating, with no nausea, vomiting, and has become gradually worse over the last 6 days. He's not clammy, his heart sounds are normal, there's no bruise, his JVP is not elevated, his central capillary refill time is below 2 seconds, radial pulses are regular plus bounding, his lower limbs are soft non-tender, and he has no cardiac risk factors, for example smoking, hypertension, diabetes, there's no family history, and he's fit. So these findings are not typical of a cardiac cause of chest pain. So for example, cardiac chest pain is not reproducible on deep inspiration, and it often radiates to the back, neck, jaw and left arm, and it is commonly associated with clamminess, nausea and vomiting. The patient also has a bounding pulse, which is commonly associated with infection. So from a respiratory point of view, his respiration rate is 24, so he's tachypneic, but he's speaking in full sentences. His O2 saturations are 95% on room air, and he's got no underlying lung pathology. On auscultation, there is reduced air entry in the left lower base, plus slight dullness to percussion and no crackles. There is equal expansion, no cyanosis, no clubbing, virtuos and epitrochlear nodes are non-palpable, and the patient states for the past 2 days he has a spontaneous productive green sputum cough with no hemoptysis. So these findings further narrow down the differential even further. For example, low O2 sats, reduced air entry, dullness to percussion with no crackles and a productive green sputum cough with a bounding pulse indicates the presence of infection, consolidation and a likely diagnosis of CAP. From an abdominal point of view, all quadrants are soft and non-tender with no splenomegaly and no renal angle tenderness. There are no midline pulsatile masses, no aortic renal artery bruise, bowels are regular with a normal stool, passing urine as normal with no hematuria or dysuria, and urine dip is negative. Essentially, the abdominal assessment is unremarkable and can now become confidently ruled out as a source of the patient's presenting complaint, which further narrows down the list of differentials. So, ruling out other sources, there's been no trauma and there are no musculoskeletal complaints. There's no evidence of shingles. The patient does not have an history of mental health issues. He is coherent with the GCS of 15 and his non-verbal cues identify that he is in genuine pain on deep inspiration. So, although at this stage the etiology of the patient's chest pain is tending towards that of a respiratory cause, other diagnostic criteria need to be taken into consideration in order to make an accurate diagnosis and prevent diagnostic error. So a chest X-ray is performed and it reveals patchy consolidation in the left lower lobe consistent with community-acquired pneumonia. His claustrophrenic angles are clear with no effusions, heart contours are normal and no cardiomegaly, the trachea is midline with no deviation, lung markings are clear and there's no pneumothorax, there are no rib fractures and no other musculoskeletal abnormalities noted. So lab blood tests are back. His troponin is normal, it's below 14. His C-reactive protein is slightly raised at 78 nmol, which is indicative of the inflammatory process. His full blood count reveals a slightly raised white cell count at 13.8 and raised neutrophils of 12. His UNEs are normal, coagulation screen is normal, and his D-dimer is negative, and the Wells criteria score for PE is 1.5, which determines the patient to be at low risk of PE. What can we deduce from these findings? Well, we know the pain is pleuritic and has become gradually worse over the last 4 days. He's got a productive green sputum cough, which is indicative of a pneumonia. He's pyrexial, he's been tachycardic, and he's tachypneic. He's got reduced air entry to his left lower lobe, which is dull to percussion, and the chest X-ray confirms patchy consolidation in the left lower base with no effusions. White cell count and neutrophils are raised. Given all these findings and having narrowed down the list of differentials through a process of elimination and clinical reasoning, it is now safe to make a diagnosis of CAP and treat the patient with appropriate antibiotics. However, in order to safely discharge the patient home, a CURB 65 score needs to be added. So the curb score, the patient is not confused, so that's equals 0. His blood urea nitrogen is below 7, equals 0. Although the patient's respiratory rate is slightly raised, he still scores a 0 on that. Blood pressure is normotensive, so that is 0, and the patient is below the age of 65, so that is a 0 as well. So essentially, his curb score is 0, and it is safe to actually discharge this chap home. So with all this information and having worked through the list of differentials, it is actually now safe to send this chap home. You will need a GP follow-up in 1 week with a repeat chest x-ray in 6 weeks. Given that the patient is penicillin sensitive, clarithromycin 250 mg BD for 7 days is prescribed and he is advised to finish the full course. So, in conclusion, differential diagnosis is a process of elimination that uses the assessment and history-taking process to gather information on past and present symptoms. Differential diagnosis is the distinguishing of a particular disease or condition from others that present with similar symptoms. Clinical reasoning is a process by which healthcare professionals funnel their thinking towards a likely diagnosis. A list of differentials can be as long or short as you like. However, the list must prioritise the most urgent life-threatening probabilities in order of severity and eliminate them accordingly. There can be more than one diagnosis, so it is important that you systematically work through the list and eliminate all the possible causes of the presenting complaint. Differential diagnosis has the potential to improve quality of care and patient outcomes.